This conference will now be recorded.
100 members అయిన తర్వాత స్టార్ట్ చేయాలని స్టార్ట్ చేసేవచ్చు. Good morning, everyone. Am I audible?
Yes, sir.
Okay. So today I am going to talk about shoulder dislocation. So here we can understand two terms. One is subluxation and another one is dislocation. So in dislocation, there is a complete loss of connection between the two articular surfaces of a joint occurs. So if it is partial, then we can call it as a subluxation. In this image, the first one shows normal shoulder joint and second one shows there is anteriorly dislocated shoulder joint. So here we can see there is a complete loss of connection between the articular surfaces of the humerus head and that of the glenoid. So that is, this image is anteriorly dislocated shoulder joint and third one is posteriorly dislocated shoulder joint. So coming to the introduction. So shoulder dislocation is the most commonly dislocated major joint of the body. So it accounts for up to 45% of the dislocations. In this, the anterior dislocation is most common type. So it accounts for up to 96% of shoulder dislocation, whereas posterior dislocations account for 2 to 4% and inferior dislocations account for up to 1% of the shoulder dislocation cases. So incidence, it is a little bit high, and incidence is 17 per 1 lakh population per year, and also it shows bimodal age distribution. So incidence peaks for males in the 21 to 30 year age range. This is because of mainly this age group is most commonly met with an accidents and high velocity injuries, and also this group of people are more prone to sports injuries. And for women in the age 61 to 80 year age range. So this is mainly due to frequent falls, and the recurrence rate is almost 50%. And if the first episode of dislocation occurs at the age of 14 to 20 years, the chances of recurrence is almost 89%. As the age progresses, the recurrence rate is gradually decreases. So before going into the types of shoulder dislocation and how to diagnose and manage the cases, so we should know about anatomy of the joint. So shoulder joint, it is a synovial type of joint, and it is ball and socket type of synovial joint. So the components of the shoulder joint are, one is humerus head and another one is glenoid. Another one is glenoid labrum. Glenoid labrum is nothing but attachment of the fibrocartilaginous ring or rim at the end of at the margins of the glenoid, bony glenoid. And capsule. Capsule is nothing but condensation of the ligaments and fibrous tissue and ligaments. So these are the components of shoulder joint. So the shoulder joint lacks bony stability. This is mainly because of the humeral head is 3 times bigger than that of the glenoid, and it provides maximum mobility. Coming to the anatomy of the glenoid, it is pear-shaped structure, and it is a part of scapular bone. Normally it is 2 degrees anteversion to it is located 2 degrees anteversion to 7 degrees retroversion, and it is superiorly tilted about 15 degrees with reference to the horizontal axis. Coming to the anatomy of the humeral head. So humeral head forms an angle of 130 degrees with the shaft, and it is usually retroverted. So the scapula is almost 30 degrees angle. It forms 30 degrees angulation with the horizontal plane, so that the humeral head is also forms. It is 30 degrees retroverted. So it provides good connection. And another one is the articular surface of the humeral head is ovoid in shape, and usually facing medially and superiorly and posteriorly to form a connection with that of the glenoid cavity. Coming to the stabilizers of the joint, so it is two types. One is static stabilizers and another one is dynamic stabilizers. Static stabilizers are mainly due to bony components and ligaments, whereas dynamic stabilizers are mainly due to muscles around the shoulder joint. So static stabilizers are bony components in the shoulder joint and labrum and capsule and then ligaments. And also there is a negative intra-articular pressure located within the joint that provides static stabilization of the joint. And cohesive forces, joint conformity and glenoid tilt. These provides static stabilization. Dynamic stabilization mainly by the muscles. And sorry, is there any problem? Am I audible to everyone? Okay, dynamic stabilizers. Dynamic stabilization is mainly by muscles. So, and also joint motion that tightens the ligaments. So, the main component of the ligaments are glenohumeral ligament. That is the ligament attached to the glenoid and to that of the humerus head, and to the humerus head. So, it is mainly three types. Glenohumeral ligaments are three types: superior, middle, and inferior. So superior glenohumeral ligament mainly prevents the inferior dislocation or subluxation of the joint, whereas middle glenohumeral ligament mainly prevents the excessive external rotation of the shoulder joint. Whereas inferior glenohumeral ligament, again it shows three parts: anterior, middle, and posterior inferior glenohumeral ligament. So the anterior glenohumeral ligament mainly prevents the anterior dislocation or subluxation of the shoulder joint. So these ligaments are mainly helps in static stabilization of the shoulder joint. So what are the causes of shoulder joint dislocation? The most common cause for shoulder joint dislocation is sports injuries, and then accidents, including road traffic accidents, and falling on outstretched hand. Sometimes seizures and electric shocks, which can cause muscle contractions that pull the humerus out of the place, that leads to shoulder dislocation. So violent muscle contraction can also leads to shoulder dislocation. Coming to the types of shoulder dislocations. So mainly three types. One is anterior dislocation, second one is posterior dislocation, and inferior dislocation. In anterior dislocation, the humerus head lies anterior to the glenoid cavity. So that is anterior dislocation. Again, it is divided into three subtypes, in which the most common type of anterior dislocation is subcoracoid. 90% of the anterior dislocations are subcoracoid type. In this, the humerus head lies anterior to the glenoid cavity and below the coracoid process of the scapula. And the second one is preglenoid or subglenoid. Here, the humerus head lies anterior to the glenoid cavity and below the glenoid cavity. Third one is subclavicular. So this is also known as intrathoracic type of anterior dislocation. The chances of injury to the lungs and more common with this type of anterior dislocation, and it is very rare type of anterior dislocation, subclavicular type is. So second one is posterior dislocation. The most common cause, most common type of posterior dislocation is subacromial. Here the humerus head lies posterior to the glenoid cavity and below the acromion process of the scapula. So almost 98% of the posterior dislocations are subacromial type of posterior dislocations. Second one is subglenoid. Third one is subspinous. It is very rare type of posterior dislocation. And another type of dislocation is inferior dislocation. So it is mainly due to hyperabduction injuries. So it accounts for almost it is very less type of around 1% of the subluxation or dislocation. Anterior dislocation, the mechanism of injury is mainly due to a blow to an abducted, externally rotated and extended extremity, and also fallen outstretched hand. Sometimes the dislocation occurs with the posterior humerus force or fallen outstretched arm. On examination, the arm is visually abducted, externally rotated, and the acromion appears prominent, and patient is unable to do internal rotation. Internal rotation is very painful in this patient. So what are the injuries that are associated with anterior dislocation? So that includes nerve damage. So most common here in anterior dislocation or inferior dislocation or posterior dislocation, the most commonly involved nerve is axillary nerve and fractures. So anterior dislocations are most commonly associated with greater tuberosity fractures and tears. Tears that includes glenoid labral tear, rotatory cuff tear, and ligamentous tear. Here you should know about two lesions. One is Bankhart's lesion and Hill-Sachs lesion. So this image, in this image, here it shows there is a fracture at the anterior-inferior portion of the glenoid cavity. That is Bankhart's lesion. So this is on the side of glenoid cavity, and here it shows Hill-Sachs lesion. Hill-Sachs lesion is the lesion that is located at the posterolateral aspect of the humeral head. So these lesions are most commonly seen in anterior dislocation, and these lesions are main culprit for development of recurrent shoulder dislocations. Coming to the posterior dislocation, the mechanism of injury is hit to the anterior shoulder and axial loading of the adducted internally rotated arm. It may also be a result of violent muscle contraction that is seen in seizures and electrocution. On examination, the arm is usually held in adduction, internal rotation, and patient is unable to rotate externally. Associated injuries with posterior dislocation are fractures of the surgical neck of humerus, or here the lesser tuberosity is mainly involved. Whereas in case of anterior dislocation, the greater tuberosity is involved, and along with that, there is a Hill-Sachs lesion. That is involvement of the posterolateral aspect of the humerus head. And here reverse Hill-Sachs lesion, also called as McLaughlin lesion. So here in this image, there is a defect in the anterolateral portion of the humerus head, that is Hill-Sachs lesion. Whereas in case of posterior dislocation, what happens? There is a bone deficit at the region of anteromedial aspect of the humeral head. So exactly counterpart of the Hill-Sachs lesion. That's why we called it as a reverse Hill-Sachs lesion. Coming to the inferior dislocation, the mechanism of injury is hyperabduction injuries or with axial loading on abducted arm. On examination, the arm is held above and behind the head, and patient is unable to adduct arm. So inferior dislocations are most commonly associated with neurovascular injuries. So here also the most commonly involved nerve is axillary nerve, and associated with axillary artery injury. Along with that, there is injury to the rotatory cuff muscles and tear in the internal capsule. So coming to the history, patients may report felt a popping sensation, and sometimes they're complaining of sudden onset of pain with a decreased range of motion, and sometimes they felt sensation of joint rolling out of the socket. Always remember to ask about any previous dislocations. So this is mainly helps in to diagnose the Hussex lesions and Bankert's lesions and other bony injuries or ligamentous injuries. Diagnosis is mainly confirmed by one is physical examination and another one is radiological examination. Physical examination should confirm a suspected dislocation. The range of motion is diminished and painful. The normal round contour of the shoulder joint is lost in case of shoulder dislocation and it becomes flattened. In thin patients, there may be a prominent humeral head felt anteriorly in anterior dislocation, posteriorly in posterior dislocation. So neurovascular examination is very important. So the most common involved nerve is axillary nerve. For that, we have to examine the motor component and sensory component. In this image, the first one shows the examination of motor component of the axillary nerve. So this image shows there is an examination of the motor component of the axillary nerve. Here the patient is trying to push the flexed elbow towards the examiner hand, and here the examiner palpate the contraction of axillary deltoid muscle. So axillary nerve mainly supplies the two muscles. That is, one is deltoid muscle. It mainly produces abduction of the shoulder joint, and another one is teres minor. So it provides external rotation movement at the shoulder joint. First one, motor component examination for deltoid muscle. So examination of the motor component is very difficult in a case of acute shoulder dislocation because of the pain. So sensory examination is this is very helpful to know the status of the axillary nerve function. So the axillary nerve mainly supplies the lateral aspect of the arm. So we have to check the sensation over the anterolateral aspect of the shoulder joint, and also check the distal pulsations. Clinically, two tests are available. One is Diogas test, another one is Hamilton ruler test. What happens in Diogas test? Diogas test positive means the patient is unable to touch the opposite shoulder with that of the affected arm. That is Diogas test. Positive means the patient is unable to touch the opposite shoulder with the effect of with the affected arm. Negative means normal shoulder joint. Hamilton ruler test. In this test, normally, if you place a ruler over the lateral aspect of the arm, it touches either acromion process or lateral epicondyle of the humerus because of the normal contour of the shoulder and deltoid bulge. Whereas what happens in case of shoulder dislocation, there is a flattening of the lateral aspect of the humerus, lateral aspect of the arm occurs. This is mainly because of the loss of contour over the shoulder joint. So in this case, if you place a ruler over the lateral aspect of the arm, so it can touches both acromion process and lateral humeral epicondyle. Radiological examination by X-rays and CT scan. CT scan mainly helps you in case of dislocation associated with fractures. The most commonly used radiological method of diagnosis is X-ray examination. So we can order antero-posterior view, scapular Y view, and axillary view. Here the scapular Y view is most important because posterior dislocation is easily misses in the antero-posterior radiograph. So it is clearly visible in the scapular Y view. So this image shows how to get AP view of the shoulder joint. Here the patient is the cassette is placed behind the patient and patient is rotated approximately 40 degrees toward the affected side, and the central beam of rays is passed through the directed towards the glenohumeral joint. So this is the true AP joint, AP view of the shoulder joint. Here we can clearly see the contour of humerus head and glenoid cavity. This is the axillary view. So here we can see mainly see the contour of the glenoid cavity and also humerus head. So this is the coracoid process. So it indicates the anterior portion of the joint. This is the acromion process. It indicates the posterior aspect of the joint. And this is a image of shoulder dislocation, anterior shoulder dislocation. First one is AP view. Second one is scapular Y view. So in this AP view, we can see the dislocated humerus articular surface below the coracoid process. So red mark indicates glenoid cavity, whereas blue marks indicate the humerus head. So this is the scapular Y view. So here, also known as transthoracic scapular view. Here in this image, the red one shows the glenoid cavity, and anteriorly this is a coracoid process, and posteriorly this is a acromion process. And the humerus head is located anterior to the glenoid cavity, so it is anterior dislocation. So this one also anterior dislocation of the this image also shows anteriorly dislocated shoulder joint, and it is a subcoracoid type of dislocation. Other views that can help in case of recurrent shoulder dislocations are axillary view, Hill-Sachs view, and Stryker-Nash view. West point axillary view mainly helps in diagnosis of Pankot's lesion, that is injury to the anterior inferior part of the glenoid cavity. And Hill-Sachs lesion and Stryker-Nash view mainly helps in diagnosis of Hill-Sachs lesion. So this image shows posterior dislocation. Here in the AP view, this second image shows after reduction. So in the first image, it is difficult to diagnose whether the shoulder joint is dislocated or it is normal. So this is also known as a light bulb sign. The humerus is completely rotated internally and a head appears like a bulb. So this is also known as bulb sign. So for the identification of posterior dislocation, we must order the scapular Y view. In the scapular Y view, the humerus head lies, if it lies posterior to the glenoid cavity, that is posterior dislocation. This is this image shows after reduction. So this is the inferior dislocation of the shoulder with fracture of the greater tuberosity. Here the humerus head is located below the glenoid cavity. Then coming to the management. So the treatment part is mainly the closer direction with the help of anesthesia and muscle relaxant. So several reduction techniques are available for anterior dislocation. Mainly we can use the Milch technique and axonal rotation technique. So these are the reduction techniques for anterior shoulder dislocations are, one is scapular manipulation. So here in this scapular manipulation, patient is in a supine position or in prone position. The examiner or the practitioner using one hand at the tip of the scapula and try to push it medially, and another hand place over the patient elbow and try to give traction along the direction of deformity. So most of the dislocations are reduced with this type of manipulation. And another one is axonal rotation technique. This is the most commonly used reduction technique, anti-shoulder reduction technique. In this, we have to exaggerate the axonal rotation deformity of the shoulder joint. So it leads to disimpaction at the site, and after that easily reduced. And another one is Milch technique. In this, so in orthopedics, for any dislocation, first we should give traction along with the deformity direction. So the steps involved in any joint dislocation, one is disimpaction and another one is reduction. Always everyone must exaggerate the deformity at the dislocated site and then do reduction. So other techniques are Milch technique, Stimson technique, and traction counter traction technique, and Kocher's and Hippocratic technique. And Kocher's and Hippocratic techniques are associated with high energy traction. So it is no longer recommended due to high risk of complications, mainly brachial plexus injury. And posterior dislocation is reduced by one technique, that is the patient is in the supine position, an assistant applies anterior pressure to the humeral head, while examiner applies axial traction to the humerus with internal and external rotation of the humerus. Inferior dislocation is mainly reduced by traction and counter traction method. So here avoid multiple attempts, otherwise it may lead to neurovascular injury, mainly brachial plexus injury. So what are the contraindications for closed reduction? One is reduction associated with fractures of the humeral neck and head and suspected arterial injury. Delayed presentation to the emergency department, that is more than 6 weeks. If prompt reduction cannot occur without further injury, that needs surgical help. So after reduction, place the, in case of anterior dislocation, place the arm in adducted and internally rotated position, and apply a arm sling. And after reduction, mobilization should place for 2 to 3 weeks. In younger patients, we should keep the mobilization up to 5 weeks, followed by gradual mobilization of the shoulder joint. So what are the indications for surgery? In case of anterior dislocation, failure of closed reduction and soft tissue interposition, if the dislocation associated with fracture displacement of the greater tuberosity and glenoid rim fractures. So in case of posterior dislocation, the indications for surgery is major displacement of the associated lesser tuberosity fracture and fracture of posterior glenoid fragment. If the dislocation is open dislocation and with the fracture involving the anteromedial aspect of the humeral head, that is reverse heel sac lesion, and recurrent instability. These are the indications for surgery. Surgical options includes repair of the capsule, and also it includes glenoid labral repair. In case of Bankart's lesion, there is a injury to the antero-inferior portion of the glenoid labrum occurs. So in that case, Bankart's repair is mainly helpful. That is nothing but labral repair. And another one is ligamentous repair. Another one is bony transfer. Bony transfer, one of the procedure known as Letarjet procedure. In this process, this is mainly used in anterior dislocation of shoulder. So here the coracoid process placed in front of the glenoid cavity so that it prevents the recurrent anterior dislocation. And muscle tendon transfer. So the most commonly used operation is putty plate operation. This is mainly for anterior dislocation of the shoulder. Here we can detach the subscapularis from the lesser tuberosity and attach it to the higher place so that it prevents anterior dislocation of the shoulder. And hemiarthroplasty. If the shoulder dislocation associated with fracture of the humeral head, more than 20% or 40% of the humerus head, then it needs replacement of the humerus head. Complications associated with shoulder dislocations are bony injuries, rotator cuff injuries, and capsular and subcapsularis tendon tears, and vascular injuries and nerve injuries. These vascular injuries and nerve injuries are most commonly associated with hyperabduction injuries. That is nothing but inferior shoulder dislocation, also known as luxatio erecto. Thank you. Any doubts? Okay, thank you.